Hi, this is Elliot Fishman, and this lecture will be on CT urography after urinary diversion and other surgical procedures, looking at some potential complications. And this is something we are doing a lot of with CT urography these days. We see a lot of surgical patients at Hopkins, whether it's prostate surgery or bladder surgery. A lot of interesting cases, and this is an article that's going to be coming out in Radiographics by Dr. Kawamoto. Now, urinary diversion is a well-established urologic procedure. Its main indication is to improve or replace the function of the urinary bladder in patients with bladder cancer, neurogenic bladder or bladder dysfunction, detrusor overactivity, and in chronic inflammatory diseases of the bladder. For treatment of muscle-invasive and refractory bladder cancers, cystectomy with a urinary diversion is considered the gold standard. Different techniques for urinary diversions have been presented, the most common being the incontinent cutaneous diversion or conduit, the continent cutaneous catheterizable reservoir or pouch, and the continent urinary diversion to the intact native urethra or the orthotopic neobladder, which we're seeing more of these days. During the past decade, as surgeons have gotten better, this orthotopic reconstruction is becoming more and more common. Not surprisingly, this is very difficult surgery, difficult patients, and so complications are not uncommon. And we can look at complications as acute and as chronic, or early and late complications. And so some of the things we look at. We talk about early complications. We talk about the first 30 days after surgery, and these include bowel complications, be it ileus or obstruction or leak, infections, typically UTI or pelvic abscesses, post-op fluid collections ranging from urinomas to hematomas to lymphoceles, to urinary tract complications like anastomotic leaks or obstruction or ischemia. Chang looked at complications within 30 days of radical cystectomy and showed that a complication rate was a bit over 30%, with post-op ileus the most common complication, affecting 18% of cases. Reoperation for early complications was done in about 3% of continent reservoirs and about 7% of orthotopic bladder reconstructions. Long-term complications of those beyond 30 days include stone formation, infection, transmission of high bladder pressure to the upper urinary tract with reflux, and physical obstruction at any site in the course of the reconstruction, most commonly at the uretero-ileal anastomosis, which may result in decreased renal function. Correctable causes should be identified early to prevent these type of complications. Reoperation for late complications overall was done in about a third of cases in the continent catheterizable reservoirs and about 13% in the orthotopic bladder substitutions. Now, in the past, IVPs and retrograde studies were common studies to be done. Lupograms were common studies. But CT urography has the ability to detect both the normal and abnormal post-op findings in patients with urinary diversion. And again, we can look at both the upper tracts and lower tracts, look at the anastomoses, look for distant mets. At the same time, we look for complications. And in this exhibit and in this article and in this talk, we're looking at some of the techniques of CT urography and some of the complications that we easily can see. So our typical examination requires non-contrast cortical-medullary and excretory phase imaging. A key thing, of course, is to wait long enough. There is some decision processes that go on how long you should wait. For the orthotopic, we'll typically wait up to about 10 minutes. Again, waiting a bit longer is better than waiting too little. Too early, you're not going to get good opacification. In terms of non-contrast CT, its best advantage is having stones being able to be detected. But the truth is, with early phase imaging, I can see stones anyway. So to decrease radiation, typically a cortical medullary phase and probably the delayed phase or excretory phase with CT urography is all that may be necessary. In terms of technique, we like to use the combination of axial images as well as post-processing. Again, the phases you use will vary between institutions. Some people like a nephrogram rather than cortical medullary phase. But again, I think either works very, very nicely. So it's something to think about. Now, if you look at some of the diagrams we showed here, these are illustrations of urinary diversions. And you can get a feel of what is actually being done, how you're reconstructing the ureters, and the bowel and that anastomosis, and you can see how you would expect things to look. So if you take and think about those anastomoses, here's a typical normal post-op appearance, and you see the case on your right, duplicated collecting system. You can see the ureters nicely opacified. You can follow them to the ileal orthotopic neobladder. Case on your left, normal CT urogram after ileal conduit urinary diversion. Again, very nice visualizations. You can see the patient had cystectomies in both cases, multiple pelvic clips, no problem. Next case. Here's a good example of being able to see leakage. And in this case, you're seeing leakage from the anastomosis. It's a not uncommon early complication. Sometimes this will need to be drained. This is a patient with the leak was from an ileal orthotopic neobladder. The patient was recently post-cystoprostatectomy with ileal orthotopic neobladder reconstruction, and the patient now presented with abdominal pain, nausea, and vomiting. You can see why you need to wait long enough to be able to get that very nice opacification. Or in this example, another case of a leak from an orthotopic neobladder. Now, some people will say is you can inject into the bladder. We find that as long as you wait long enough, you can do a fairly good job. Image on your right, you can see leak from the distal right ureter. Again, very nice visualization. 3D mapping, I think, is very important in these cases. Gives like a global perspective, though I would have to admit, if you look at case on your left, it's fairly easy to see contrast extravasation looking only at the axial images. Another case, post-surgical fluid collections. Now in this case, we thought there was a hematoma present. Hematomas, seromas, urinomas are all possible complications. But when we gave IV contrast in this patient, look at that marked enhancement. That was a great case. That's a pseudoaneurysm. The angiography showed the pseudoaneurysm with feeding vessels from the internal pudendal arteries and left obturator. This patient was subsequently embolized, but what a great case. It also shows you why IV contrast is so important. If you don't have IV contrast, you just think there's a bleed present, and you might percutaneously drain this. What a disaster. Another case, stricture or questionable stricture. Again, you can see right hydronephrosis. Again, you can wait longer, but we've noted this before when we talk about CT urography that sometimes you can wait like forever. We know that from IVPs, and the ureter doesn't opacify. What's very nice about CT is the non-opacified ureter is really opacified with urine when it's obstructed, and you can very nicely see the transition, and particularly when you give IV contrast, that transition point does enhance. So it works out very nicely in that regard. Or here's another case where we can show very nicely the CT urogram. We see on the left the contrast extravasation, the perirenal fluid. We can see the bladder. We can see obstruction of the distal left ureter. And this was a stricture. So again, using a combination of 3D images, early and late phase, axials, coronals, and 3D maps works very nicely. Now, in terms of complications, we know stone formation is one of the late complications. This patient, the status post-continent urinary diversion with colonic augmentation many years before, almost 2 decades before. Now the patient has recurrent urinary tract infections, and you can see the presence of stones very nicely shown in the left kidney. So again, these patients do have that as one of the later complications. Or here's a case of calculi in the ileal conduit and in the left kidney. So again, calculi are not an uncommon complication, but those are typically late complications because of the changes related to all of the patient's surgery, something we know about. UTIs are not uncommon. They can occur early or they can occur late. Again, any patient where you do very complicated surgery, the ability for reflux, the ability for infection is not uncommon. If you don't pick it up early, you can lose renal function, and that indeed can be very critical. There's an article by Matzenbacher found that radiographic or functional deterioration of renal function was observed in about 1/3 of patients at minimum follow-up of 5 years, and this increased to 50% in those followed for 15 years after ileal conduit urinary diversion. So again, you want to be on top of things, and these patients are monitored very closely. Nice example of dilated renal pelvises bilaterally, filling defects in the left renal pelvis, which represent clot or fungus ball. This was infection. Patient was treated and did fine. Or this example, another case of recurrent urinary tract infection. Look at the loss of cortex in the left kidney. Again, these patients are at risk for these complications and so need to be monitored very carefully. You can develop fistulae. Again, fistulae occur with surgery. Here's a case of a ureteroenteric fistulae. It's an uncommon complication after radical cystectomy and urinary diversion. It's reported in about 2% of cases in some of the larger series, but it does occur, and this is just a very nice example of showing that. Now, when we talk about complications, I guess once you talk about long-term complications, you talk about tumor recurrence. Tumor recurrence is what you might expect. Adenopathy, recurrence in the surgical bed. Most people will follow the patients annually. And again, tumor recurrence can occur almost anywhere. Liver mets are uncommon without other disease. With transitional cell carcinomas, they're often multifocal, so the contralateral renal involvement is possible. There's a number of different articles, and here's some of the references on this slide that make that point. So again, we need to be very careful in looking at these patients. Here's an example with bone metastasis and liver mets. And here's a patient with multiple transitional cell carcinomas 2 years after cystectomy and left ureterectomy with ileal interconnection with a content diversion for refractory bladder cancer. So again, in this scenario, not only was there bladder involvement, but later on there became involvement of the ureters and renal pelvis, just an aggressive disease and multifocal disease. Or this example, a high-grade transitional cell carcinoma in the left renal pelvis 1 year after radical cystoprostatectomy and ileal conduit diversion for bladder cancer. So again, we always need to be very careful on these patients. Once you have that first tumor, it's very easy to get seeding, and you may not pick it up early, but you need to be monitoring these patients. Or another example, look at this case. Look at the left kidney. Look how there's tumor infiltration. It's a transitional cell carcinoma. This is just 4 months after radical cystoprostatectomy. So again, the timing can be very tricky. One could argue in this case perhaps something was missed early in the renal pelvis, and that's why there's so much tumor so quickly. But again, things will vary. And again, it's just another example, transitional cell carcinoma of the left renal pelvis on your left. And another example of a subtle renal lesion in the left renal pelvis. So again, small and large lesions, but again, you need to be monitoring very carefully. And when you monitor these patients, again, think about the complications from infection to urinomas, seromas, to tumor. Again, tumor you're not going to worry about early, but I did show you a case 4 months later. So again, something to consider. Now, sometimes in these patients, you can have complications not related to the urinary diversion. This patient had a wound infection. You can see hernias. So again, common complications unrelated to neobladder reconstruction were incisional hernias and bowel obstruction. So anybody who has surgery, particularly extensive surgery, gets adhesions, gets bowel obstruction, and incisional hernias do occur no matter how careful you indeed are. So concluding then, CT urography plays a major role in these patients with urinary diversions. We can recognize the normal appearance and the abnormal appearance. We recognize early and late complications. Critical thing is technique. Again, axial images, as I showed you, are not enough. 3D mapping becomes very critical. And again, when you examine these patients, particularly after a few months out, think of the gamut of complications from neoplasm to inflammatory disease. And I think if you do that, you'll be very successful picking up these critical findings. Now with that, I wish you a great day.